That's one, two.
Are we supposed to sit? Are we supposed to sit in this want to sit here? Or no? I don't mind. Oh, no, no, yeah.
I guess that is. That's one, two.
think we are.
You let me know. Well, we're getting a.
Online audience, please stand by. We will be getting started in about 5 minutes. In-person audience in about 5 minutes. We're just waiting for a few more people to come in. Microphone check for Lebanon. Microphone check for Lebanon. Can you hear me?
Thumbs up for Russell. We're going. He can live with it. All right, we're gonna go ahead and get started. Good evening. Welcome to this very special event. My name is Dr. Lisa Warren. I'm a 2001 Comp graduate, Associate Professor of Pediatrics. Yeah, thank you. And I'm the chair for the Austin Lectureship Committee. I'm excited to welcome you all to the 9th Dr. Robert L. Austin Endowed Lectureship in Pediatric Medicine, Pharmacology, and Healthcare Policy. I would like to extend a special welcome to the representatives from the university's Board of Trustees and Administration, as well as the college deans. Welcome, thank you. Thank you for all your ongoing support for this lectureship. The Austin Lecture was established more than a decade ago, thanks to the generous donation from Mrs. Gloria L. Austin in memory of her husband, Robert, a pediatrician, Comp faculty member, and an early supporter of Western U. Additional gifts from the Austin family over the years not only ensured that this lectureship will continue in perpetuity, but also now funds 2 annual scholarships that help students on their path becoming healthcare professionals for tomorrow. On behalf of Western U and the Austin Lectureship Committee, I'm honored to extend a sincere gratitude to the Austin family here today in the ongoing support of our mission and our students. Their impact is felt within our community, our classrooms, patient care centers, and in all of who benefit the knowledge and resources because of the family's contributions. Please join me in welcoming the family members, Lynette Austin, Liz Fields Austin, and Linda Goldman. Whether you're joining us in person or watching online, we hope you leave today's lecture inspired, invigorated, and ready to continue taking on the challenges ahead in healthcare. Your involvement in Western U community is critical to our continued growth, success, and recognition as a leading health professions university. Before we get started, I want to note that at the conclusion of this lecture, we're going to have a Q&A session, so please hold your questions. And for those online, you can go ahead and type those in the chat so we have that ready at the end of our session today. Now I'd like to introduce you to Western U's president, Dr. Robin Farias-Eisner.
Thank you, Lisa. Thank you. Thank you. So welcome to all of you that are streaming from different parts of the globe, Lebanon and the surrounding area, Pomona surrounding area. Special welcome to the family, to Gloria and Robert Austin's family. You've heard Lynette, Liz, and Linda Goldman. And we're very grateful. Linda Goldman actually graduated in 2013 here, Doctor of Nursing Practice. So we're want to welcome you back and thank you for your continued involvement. But it's particularly important, I think, that we honor individuals like yourselves because it very much is in alignment with our own mission. We're all dedicated to community. It's very important to us to continue that tradition, to reach out into the community and to do whatever we can to create scholarship and also to create opportunity for underrepresented communities. That really is part of who we are and what we want to continue to be. So thank you for your continued support of this initiative and these endeavors, these lectures, and so on. I will tell you that it's a small world. Our Dean of Comp, Dave Connett, was a football player at Neff High School and in La Mirada, California, where the Austin family lived. And interestingly, Robert Austin, Dr. Austin, was practicing OMM on Doug. He was a pediatrician, on Dave. Now the question is, if he was a pediatrician, why was he doing that when you were in high school? So obviously Dr. Connett was considered still a pediatric patient in high school. So I think that's, I always love those human interest stories. But welcome to our distinguished lecturer. I do want to introduce Dr. Sandra Block, and I want to first, if I may, give a little history about you, because I know you're quite accomplished. So the lecture today is meeting the increasing vision challenges facing school-age children. very, very important and critical area in my opinion, and I'm sure you'll agree with me that pediatric and school-age children are an important population to help. And in this case, vision, how can they succeed in the classroom if they can't see? And that is something that we all recognize as very important. Dr. Block received her OD degree and completed a pediatric residency at Illinois College of Optometry, where she went on to serve as a faculty member for 39 years before retiring as professor emeritus in 2020. Along the way, she completed her Master of Education at National Louis University and a Master of Public Health at the University of Illinois School of Public Health. And her last faculty position was as the medical director of the Illinois Eye Institute at Princeton School, a school-based vision clinic serving low-income children in Chicago. Dr. Block is past chair of the National Center for Children's Vision and Eye Health and has recently joined the Vision 2020 USA Board of Directors. After 27 years, Dr. Block recently retired from her position as Global Clinical Advisor and consultant to the Special Olympics Lions Club International Opening Eyes Program, where she was instrumental in developing the Global Vision Program to address the lack of access of vision to people with intellectual and developmental disabilities. Dr. Block is a fellow of the American Academy of Optometry, a diplomat in public health and environmental vision section, a fellow of the College of Optometrists in Vision Development, a distinguished fellow of the National Academy of Practice, and just last year was named a fellow of the Association for Research in Vision and Ophthalmology. Her interests lie in primary care for children, vulnerable populations, and persons with disabilities, as well as public health issues facing the equity and quality of eye care delivery. She's authored numerous publications, conducted presentations nationally and internationally, and currently serves as the president-elect of the World Council of Optometry. Apart from that, she hasn't done much. So we're very grateful that she has taken the time to be here with us. And while she's getting hooked up for Wired for Sound, I'll tell you that our university, as you know, is very committed as well to those underrepresented, to those with disabilities. And so it's very apt that we welcome Dr. Block. Thank you very much.
Thank you very much. So the purpose of my presentation is going to be to talk about school-age children, but I'm going to save that to the end. I actually have two goals today. My first goal is really to talk about the global issues, and the global issues as they respond to the equity and equality that you just heard, but also about accessibility, affordability, and equity. So that I'm going to start with the United States, and then I'm going to go to the World Health Organization, and then I'm going to come back and talk about vision issues as they affect young children, because it's a nice flow about how we can do better in assuring that the children in the United States actually see well. But before I do that, I wanted to say a thank you for the opportunity to be here. You know, as I looked at the information and I listened to the introduction, I noticed that Dr. Austin was a pediatrician, that he was a faculty member. He was truly a visionary, from what I understand, for this College of Osteopathic Medicine of the Pacific. And most important to me, he was a family man. He was father, he was a father-in-law, he was a husband and a grandfather. Made him a real person, a person that I really respect, and I feel so honored to be here. I want to thank your mother and her insight to ensure that his name and the remembrance of what he did and contributed here at Western U was remembered for eternity. So with that, thank you. And now I'm going to go to work. So let's start with public health in the United States. Years ago, there were a lot of people in public health that felt that vision and eye health issues were not even being acknowledged as a significant problem. And there were a couple of these people who were really very vocal about it, people from the CDC and from other nonprofits. What they did is they gathered enough excitement and interest and money, because in order to do this next step, you had to have $1 million because it cost $1 million for the Institute of Medicine then, and the National Academy of Science, Engineering, and Medicine is their current name, to be able to look at you to initiate the process. And we were very fortunate enough, because they were such powerful individuals, they encouraged a number of organizations to donate and participate. And as a result of that, a report titled Making Eye Health a Population Health Imperative was launched. It took 2 years. The group that was sitting at the table talking about this long before it actually became a true document was made up of a very diverse group. There were 3 ophthalmologists, 3 optometrists, 2 physicians, a nurse, a person involved with grieving, which had nothing to do with anything we were talking about, a patient, as well as a doctor. And one other person that is oftentimes ignored is a person from the public health department. This person was from the New York Public Health Department. We had some specific goals that were the responsibility of us to do. And I'm going to tell you, it was very difficult for me as a clinician working in an optometry school to think population health and not individual patient care. It's a very different perspective and requires you to have a different mindset because the solutions are not going to be the same. So the goals for this NASEM report, which is now the way it is referred, were number 1, we had to look and characterize what the true burden to the public health system of vision and eye health was. We need to look at things that were out there already, what were innovative models of care, including some of the technology, which are very different than they are today, and see if any of those would be applicable to solving some of the vision and eye health issues, and whether there were specific barriers that would preclude them from success. We needed to identify strategies to ensure that we can look at these kinds of models and decide whether they were appropriate. We had to be able to develop them, test them, and identify whether they were successful or not. And the last part was probably, to me, the most challenging, is we had to move vision and eye health issues up the ladder to a level that it was considered a significant public health priority. There's lots of other things going on in the world, so that vision and health may not have been important to a lot of people sitting at that table, but they were all there for the same reasons, and we knew we had a lot of challenges ahead of us. What we did do is we started to look at the issues. The issues, when you talk about vision, start from the very early stages of awareness and identification. I mean, we know that the dental groups have done such an amazing job ensuring that all of the families understand the importance of dental care and starting early. But we've not really figured out how to do that in vision. And that was a population shift. So we started talking about how do we initiate the process? How do we ensure that vision and eye health are maintained in a normal status? Then we had to look at the issues that come up as we start to see, screenings are designed to identify when there's somebody at risk for a disease before you actually know it's there. So we need to know what to think about in ensuring that access before the disease entity is present. Then we also had to think about making sure the people we know who have the disease are actually going to be identified and have access to the appropriate treatments, knowing full well that that is not always the case. Certainly in a high-income country like the United States, why did I have to have a clinic where people didn't pay for their services, whether it's glasses or other services that we provided? And then the last part, we as a profession don't always include this part, but there is the fact that there's a lot of vision and eye health issues that yield visual impairment. And our goal needs to be to ensure that we provide that next step. And that next step is not just the healthcare, it's the rehabilitation, it's the social issues related to maintaining independence. There is enough research to show that one of the senses that people worry about most losing is vision. And that means that if they lose vision, we see a higher prevalence of depression, and the comorbidities with vision loss and depression go up as somebody ages, and we have an aging population. So as we sat around the table, we got the opportunity to work together for 2 years. Most of the work was done remotely, but we'd come together, I believe it was 3 times a year, and we had to define what is the problem? What do we want to answer in this report? We need to really get a good sense of what the issues are as they relate to vision and eye health. I've alluded to some of them. We know the aging population. We know that non-communicable diseases are increasing. There's lots of vision issues. We know that vision care services are typically not integrated into a general health team, whether it's optometry or ophthalmology. Is optometry, most of us work away from the healthcare system in small practices or corporate entities, or even if we're in the community health center, we're back in the corner. And ophthalmology is oftentimes somewhat secluded from the rest of the healthcare team. The gentleman from New York who was a public health person also talked about the fact that I have no money. I have no resources to make changes. How are we going to change that process? And then we also looked at the fact that if you look at the data from the CDC, and the CDC is responsible for reporting on prevalence of diseases, we are basing our surveillance on very few data sets that are reliable. They're either patient reported, inconsistent, or not done for all of the individuals. Oftentimes, people who are incarcerated or living in isolated programs are not included in most of the survey data. And then the other thing is there's a lack of cross-disciplinary, we called it cross-disciplinary instead of interprofessional, but cross-disciplinary workforces. So at that time, the issue really was very strong about how it fit into the social determinants of health. I'm sure all of you are intimately aware of all the pieces of this puzzle, but the puzzle is really significant in making a decision how you're going to move forward. We know that the individual influences are very significant, whether it's their demographic pieces or their behavior. We know the family and the social constructs that they live in are important. We know that whether they have a decent job or living in conditions that are appropriate for their needs are all appropriate. Social determinants of health are not limited to the social constraints that we're talking about in those things. It also relates to access and quality of healthcare that's there. So that was one of the challenges that we were going to try to solve. So what we did is we came up with this diagram, and this really does provide a pretty significant broad base of where we're going to go. In the center of it is really how are we going to improve eye care access? But there's lots of pieces. We realized there were 5 general areas that really needed focus and change or action items. We needed to do a better job in making sure the public was aware of vision and eye health issues and the importance of accessing care before the damage was done. We know that based on the poor surveillance systems that we had, we needed to get better evidence. And thank goodness, since this time has taken place, there has been a lot of support in expanding and improving surveillance at the CDC. We know that we needed to expand access to clinical care because there's lots of populations that are not able to access it for a number of reasons. And when I get to the next section, I'll give you some sense of that. We needed to do a better job in public health capacity. We're not just talking about the healthcare system. We're talking about accessibility. We're talking about changing communities so people with visual impairments can get around independently. And then we needed the communities to have a buy-in to that. So now I'm going to take you to the international level. And the only reason I'm started with the national is because of the chronology. Many of the things I just talked about were done in the US, and then comes the World Health Organization. And lo and behold, around the same period of time, they were starting to think about developing the first ever World Report on Vision. The first meeting I went to was in 2014, and there was a whole array of stakeholders: ophthalmology, optometry, nonprofits, political people, sitting at a table under the auspices of, we want to do a vision report. What do you think should be included? We sat there for 2 days and had a whole list of all the disease entities we wanted to talk about. And everything that was said in that room was lost, because when you hear the things that was focused on, you're going to see that WHO took a very different perspective. The second time I went to Geneva to participate with the preparation of this document, the person who was now in charge was somebody who was not a vision person. She came from the disability community, and she looked at vision from a very different perspective than any ophthalmologist or optometrist. She looked at it, number one, from the fact that when you wear a hearing aid, you are hearing impaired, right? Even though with the hearing aid, you may see well. Her equivalent to that concept was, if you have a pair of glasses, just because you see 20/20, you are still visually impaired when you take your glasses off. So when they came out with the new data in the World Report, when it actually was launched, the data set showed a significant increase, but the only reason it was different was now being counted in a different way. The other thing she talked about is she said, I've been doing my homework. I've been looking at all the literature on visual impairment in groups all over the world, and I don't understand it. Visual acuity is recorded differently in almost everything she looked at. It was either uncorrected binocular, uncorrected monocular, corrected or with best correction, monocular or binocular, or it was what they walked in the door with. And she decided that we needed to be more consistent in how we looked at things. So she used uncorrected monocular visual acuity. She also moved visual impairment from 20/60, which it was, down to 20/40. I don't know how she did it, but she convinced people to do it. So that is pretty typical for what we do in the US, but outside the United States, it's not like that. So here are some things that came out of the World Report on Vision. And if you look at the top, you see the one thing that is really most important here. Everybody, if they live long enough, will experience at least one eye condition in their lifetime. Could be something insignificant like a conjunctivitis, a cataract. It could be something devastating like a retinal detachment. But the fact is, everybody will be touched at some point in their life. The other thing that was really interesting is they looked at the people who had visual impairments and identified that cataracts and refractive error were two conditions that were the highest prevalence and also had something that you could do to improve outcomes. Those are all preventable or treatable issues. But the cost factor associated with it at that point in time was $14.3 billion. So clearly there was an issue. The other thing is that, and I'm going to have to go back because I want to use the mouse. So the other thing that was interesting, we know the population in the world is aging. So they showed that with the aging population, there's going to be an increase in significant causes of visual impairment as it relates to macular degeneration. From 2020, we expected 195 million to 2030, which is only 10 years, 243 million. And with glaucoma, we will see increases that are very similar. The fact is, those are significant problems and problems that we can do something about, at least with earlier intervention for glaucoma. And now we have some treatments for macular degeneration. So the other thing that we did within that World Report on Vision is they came up with some concepts that were really important concepts. And they said, eye care needs to be integrated into universal health coverage, that we shouldn't be siloed, we shouldn't be separate. We are part of the healthcare team, and that's the way it should be. The other piece that they talked about was something called IPAC, Integrated People-Centered Eye Care. And what that means is we need to look at our patients from the health promotion piece through the health, the screening, to the diagnosis, to the treatment, to the rehabilitation. We need to be there for that patient for all of that continuum. And the sad thing was that they realized that there's a lot of gaps in the data that's out there. We need to promote better quality research. So much of the data on the prevalence of myopia that was done on census tracts. It was designed really well, but it was hit and miss. It was only several places that they actually pulled the data. And they also didn't look for other things like hyperopia and astigmatism. We need to have the data, because you can't measure a change unless you have the baseline data, and you can go back and remeasure it again. And then we need to really ensure that people understand vision is important. Vision can help you. This is about the same time as they did the research in China with providing tea leaf pickers with presbyopic corrections, and all of a sudden their improvement increased significantly over those that had no near point correction for presbyopia. The other piece that's really important that came out of here is everybody should be entitled to eye care services that are acceptable to them, accessible to them, and affordable. That those three things are really part and parcel of ensuring equality for everybody. The other piece that came out of this was the fact that in order for eye care to be appropriate, we need to be part of the primary care service and have the communication both on the main level with people who are dealing with non-communicable diseases, because clearly vision and eye health are part of that, as well, and the children's health services, because we know that the vision is very important in child's visual development. We also need to be communicating with the people on the community side to ensure awareness and education about vision and vision issues is done. But we also need to communicate on the other side with the secondary and tertiary level of care. So after the World Report came out in 2019, a number of things occurred. There were a number of resolutions that really did impact vision and eye health. The first one is from the UN General Assembly, and that took place in 2019. And it basically, we were sort of buried down there. It was talking about eye health and being integrated into universal health coverage. And this is the only place it was stated. Strengthen efforts to address eye health conditions and oral health, as well as rare diseases and neglected tropical diseases as a part of universal health. Now, I know that's not much, but it was a start, and lots has happened as we've moved forward. The next part came. So we know we have an action item that we need to ensure that eye care can be integrated into universal health care. Well, WHO provides different models for low and middle income countries to address health issues. So what they needed to do was kind of create a process to understand how can we measure effective coverage? How can we measure a change? They decided to use refractive error and cataracts. They said in countries that are following the protocol, in order to be successful, you have to show a 40% improvement in addressing uncorrected refractive error by 2030. And that means 2040 or keep better acuity. And then with cataracts, you need to improve it by 30%. Now, that doesn't sound like a lot to increase in 10 years by 30%. Well, people in Latin America felt that it was almost impossible to get outward corrections of 2040. They felt 2060 was as good as they can get. And we all know that that's not acceptable levels. Another resolution that was put together came out of the World Health Assembly. And this is one where we talked about the fact that we needed to reduce visual impairment and blindness, and we needed to have effective coverage. So they taught the goal was to come up with some data and understanding that effective coverage was important. And then the World Health Assembly actually approved that resolution. So it is now a requirement for countries to follow. So there were some other things that came out of this. And with that, if you want a lower middle income country to come up with better quality of care, you need to tell them what processes they can have to address the impairments. And it was an interesting process. It was brought together by a multitude of stakeholders, both healthcare and nonprofit, as well as public health people. And what they did was they started with first deciding what conditions they were going to recommend the changes for, identify where the evidence was, because nothing was going to be done unless there was concrete evidence of success, what the interventions should be, and then the peer review process. And there was a number of diseases that were proposed, but it was really brought down to about 7 or 8. And this was actually an article, if anybody really wants to go into depth into looking at it. It was a very complex process, and optometry was part of that process in dealing with both the low vision, the anterior seg, the refractive error, and the pediatric group. So we were really very part and parcel into the process that took place. At the same time in the UN, we always, we know that lots goes on there. There's a lot of talking, but not always a lot of action. This was actually pretty exciting. The United Nations actually had a bill up that talked about effect that everyone should be entitled to vision, everyone. And it was one of the few bills in the UN that actually received unanimous approval. Nobody disagreed with the need to do that. So that gives you a little bit of the public health background. Both the World Health Organization and the United States, through the NASEM report, really do feel strongly that vision is an important issue to address. So let's go down to the things that are more related to what we see in clinic. So first, the fact is that the World Report on Vision did talk about 2.2 billion people with visual impairment. 1 billion of those don't know they have a problem or don't have access. But the piece that's important is to look at the numbers. Unaddressed refractive error were over 123 million, as well as 826 million with presbyopes. Cataracts were 65 million, and then there was a whole slew of other things that they looked at. Children, and this is not from the World Report, this is from the International Agency for the Prevention of Blindness Vision Atlas. There are 90 million children, which are 0 to 14, and adolescents, 15 to 19, that have some form of visual impairment or blindness. Many of those are simply uncorrected refractive error. I'm not going to tell you that all of them are, but there is a significant number. The most common causes of visual impairment in children really is different in country versus country. What's important to us here in a high income country is not the same as you would find in Malawi or Tanzania or India. I actually was in Malawi about last month, and interestingly enough, the issues there are more vitamin A and things like that. But for us, we really are much more concerned about uncorrected refractive error, as well as cataracts, congenital ocular anomalies, scarring of the cornea, CVI, cerebral or cortical visual impairment, depending on when you graduated, corneal scarring, ROP. But we also know that people with different types of special healthcare needs also have often associated vision problems, those with genetic problems, congenital problems, systemic problems, or accidental injuries. There's lots of people who have issues related to accidental injuries. And when you start to look at the school age group, we start to think about that's usually where we think about vision and addressing vision. That's why do we say that? Because kids start to be able to communicate, they know their letters. Most clinicians are, if you're not comfortable with kids, we'll start seeing kids around that point in time. Elementary school kids, vision is important. Vision is important for learning. Things like uncorrected refractive error, binocular and accommodative problems, posture, visual processing issues. Those things are very important for children to be able to do a good job in school. But we also have worries about sports injuries as well as accidental injuries in that group. High school kids are a little different. I don't worry so much about the visual information processing problems because hopefully they've been caught younger, but now we start to see the emergence of more uncorrected refractive errors as well as binocular vision issues. But I worry about those uncorrected refractive errors because we know there's a lot more self-esteem issues in older kids. I know that kids that have high myopes should not be playing on basketball courts with glasses, unless they're athletic glasses. There's other avocations or hobbies that put them at risk, as well as these guys are going to start driving. I want to make sure they can see to drive well. Little self-preservation here. We know that vision screenings are something that's very commonly referred to as our way to ensure that we identify all the kids at risk. The AAP has a great set of guidelines really focusing on when pediatricians should look at vision and eye health, pretty much vision issues. I'd like to say eye health, but that's more in the first year of life. Schools do vision screenings, but the problem is in the United States, only 33 states really have statutes related to vision screening, and vision screenings done at various times. Some of them are at kindergarten and first grade, some of them are second and third grade, some of them are fifth grade, some of them are doing once only during school, others do at different times. But there's some concern with that because vision is not stagnant. Vision changes over time. So vision screenings are really significant issues that we need to be aware of. The fact is, screening tool has changed. We now know that myopia is a different issue than we thought about even 5 years ago. We need to address it differently, not only as a refractive problem, which is one of the things that screenings would always identify, but more as a disease entity that will occur later on. We now know dry eye disease is something we're looking at. We need to know what the gold standard for an eye exam for a child is. And most vision screenings were originally designed to identify risk factors for amblyopia, but our thought about what amblyopia is, it's very different than it was 30, 40 years ago when we started looking at vision screenings. And now we also have the issue that we are now able to look at the potential of keratoconus or suspicions of keratoconus early on. And I'll show you a little bit about an article that was done. So vision screenings are classically the way we look at whether a child is at risk for a vision problem. Vision screenings vary. There's no standardized protocol for vision screenings in any children in school-age kids. There were things that were done from the vision and preschooler studies that I will allude to in just a little bit, and they were good recommendations, but that ended at 72 months and didn't reflect on anything. We know technology is changing. So the question is, are the screenings that we have now appropriate? Do they really work to identify the kids that are at risk? Are they available for all children? Those are big questions because, as I said, not all states actually have vision screening requirements. We've learned a lot about vision screenings over the past decade. Some of the things that we've learned are good, and some of the things we've learned are not so good. We know that not all screenings are created equal. In the school system that my clinic was in, they did the old telebinocular where you put your head in and they do a number of tests on different cards. Other places it's distance visual acuity monocularly. Some places do color vision, other places do stereo testing. There's no standardization. And what the data has shown is if a child fails a vision screening, the average time from failing that screening to actually accessing a full comprehensive eye exam is 18 months. That's a year and a half of school that they've lost. So the other thing that was done is there was a report that we did in OVS a number of years ago with Sue Cotter as the first author from the National Center for Children's Vision and Eye Health. We said, we know that children with special healthcare needs have a higher prevalence of vision problems. They should not be screened. They should receive a comprehensive eye exam. Why screen a child that's at very high risk for having either posture issues, refractive error issues, or other eye health issues? They should go directly for an eye exam. So that was one of the things that was really important. There's also different types of evidence when you do vision screenings for kids in the first year of life, neonates and infants. We really look at their ability to have eye contact, can they fix and follow, things like that. Those are usually some of the early indicators, and those were reliant pretty much on the pediatricians to pick up. They're looking for, any aberrant posture, any type of white pupil, anything that looks unusual. Family history of cataracts would certainly be something. The ones that we use in school-age screening are the two that are next. The optotype-based screening, which is really based on recognition visual acuity, and the instrument-based screenings. And the amount of technology that has changed over the past decade is just amazing. But the question still is, are they good tools or are they reliable and valid? And that still is left up to the question. The other thing that happens oftentimes in vision screenings is if a child's untestable, they say, well, let's just try him again on another day. Maybe it's just behavior, he's tired, he doesn't understand, we need to do things. The problem is many of the screenings that are done by people who come in every 6 months, and he may not get screened again. So what the study that was done showed is those children who are identified as untestable are almost twice as likely to have a vision problem and not just be a behavior or a developmental problem. And they should actually be referred for a full comprehensive eye exam. So I talked about the vision and preschooler study. They gave us so much excellent information. It was a long-term study that was sponsored and supported by the National Eye Institute and came out with great guidelines for us to work with children who are 36 to just under 72 months. We know what kind of optotype is the best optotype for kids in that age group. We know what distance we should test them at optimally. We know that we should do monocular visual acuities, and it should be different levels for 3-year-olds and 4-year-olds. We know that the chart has to be appropriately illuminated, and that when you are occluding a child, you need to not let them do their fingers because it's not going to work. So we learned a lot of good information from that, and we use it now, but it really isn't applicable to school-age children. It doesn't follow what is appropriate. Now, I'm sure you guys all have seen this. The vision and preschooler, as well as a number of other people, have come up and said, these are charts that should be thrown in the garbage. They should never, ever be used. And the reason is, number one, children do not know what half the objects are on the Allen cards, which is the one with the birthday cake. There is a old-fashioned telephone that goes on the hooks. So we're asking them to do something that's obviously not a visual task. The kindergarten chart, there's no real correlation with the true gold standard for visual acuity. And the middle chart is more inappropriate for younger kids because children don't really understand left and right well enough at the age of 4 or 5 or 6 to be able to reliably do this. So what was suggested at that early time with VIP was that we use some of the science that was designed for actually low vision patients and utilize that, making our recommendations that only charts that really follow an appropriate design should be included in vision screening, or actually should be included in any clinical test. And these are designed with a recognition optotype. The spacing is appropriate. It's uniform with some crowding. It's a Logmar design. We know the difference between the different lines is much more appropriate. It does not require any visual processing skills. And for those kids that don't know their letters or illiterate, you can always do the symbols. And the LEA symbols, when you're near threshold, will blur relatively equal if you compare the circle to the apple, a circle to the apple, and the house to the square. So really important. But the other side of the coin is, oh my God, the guys that sell these devices are at every pediatrician's office. They are looking really hard because, yes, they do an okay job of picking up myopia or astigmatism, but they're not as good for those hyperopes. And the reason that is because everybody's focused on myopia since Brian Holden came out with his original data on the increasing prevalence of myopia. The tool on the bottom is called QuickSee, and it's the first tool that's really come out with unique or new designs. It's wavefront aberrometry. I'm not convinced that this is the right device because the tool has to be held. It has to be held so it's level. And if you're dealing with children that are younger, it's a little bit more challenging. I think in the next few years, we're going to come out with tools with AI that will really make a difference in as to getting a good assessment in a clinical screening environment. But these are good, they're not necessarily ideal. So I wanted to highlight, because those tools really focus on getting a refractive error, I wanted to highlight on a comment that was published in the Lancet Commission, I think it was in 2019. It says, spectacles are one of the most effective health interventions for school-age children, reducing the odds of failing a class by 44% with an effect size greater than or equal to other health interventions. So to me, that says it all. We know that we need to get the kids who have uncorrected refractive errors into the clinic. So when we deal with school-age children, what are we most worried about? I made fun of myopia, but the fact is myopia really is it. We're very concerned about myopia. We know the prevalence is increasing significantly. Look at this data from China. The prevalence of myopia increased from 56 to 66% in the period of time from 2006 to 2015. Now, if you go into a high school in China, almost 80% of those kids have some magnitude of myopia. And the causes of myopia are multifactorial. It's genetic, it's environmental, it's behavioral, it's lifestyle, so many different things. So I talked about the data from Brian Holden. Here is an example of what he came up with. The line on the top that has a higher slope is looking at myopia prevalence from 2000 to 2030, going almost to a 3 times increase. And high myopia, what they categorized, I think in this study is -6 and not -5, went from 163 million in 2000 to 399 million in 2020. Clearly, it's an issue, one we need to address. So the World Council of Optometry really took the research that's going on very seriously. And we put out a standard of care in 2021 that said, we as a profession can no longer address myopia as simply a refractive condition. We need to look at it as a disease entity, and we need to be very serious about how we do it through mitigation, measurement, and management. We need to do a better job. The reason we say that is we know that it's not only the high myopes that are at risk for pathological myopia, it's also some of the moderate ones. And the things that we talk about are the posterior staphyloma, the lacquer cracks, chorioretinal atrophy, macular retinoschisis, myopic choroidal neovascularization, and glaucoma. And this is not the whole list. You know, there's other things that will fall on the list. It doesn't mean everybody who's highly myopic is going to get these. It means they're at a higher risk if they're a moderate to a high myope. And here's an example of why I say that that it's not only the high myopes. So this chart on the left is really the linear respect. This is the data that most of the authors will put out, but it was converted to logMAR. And if you look, the 5 populations and research projects that were listed all show that there's a significant increase from -2 to -10 in the prevalence of myopic maculopathy. It's not just the high myopes that are at risk, it's the moderate myopes that we also have to worry about. So we would prefer to not have to deal with every diopter of increasing the risk by 67%. We want to look at every diopter reduction in myopia to reduce the risk of myopic maculopathy by 40%. The thing that we have to go back to is the way we used to practice, used to say, oh my God, you're a myope, I want to protect you from developing, I'm going to undercorrect the myopia. That's no longer true. There have been a number of studies that have done that undercorrection of myopia by 3/4 of a diopter or 20/40 acuity increases the progression of myopia, not decreases it. And there's 3 studies that were done that looked at different parts of the world, and it was consistent all the way around. It did not slow the progression of myopia at all. So that is out. It should no longer be considered. So what are our options for treating myopia? There's lots of things that are out there. First, you have to decide, can you use a spectacle or should you use a contact lens? Those are the things we talked about in myopia years ago, but it's different now. We can make a decision to do one of those 2 things, or atropine may be a possibility. And if not, then you want to go back to the spectacle correction. So if the atropine is well tolerated, you might want to use that as a consideration as a single treatment or as a combination treatment. There's lots of ways of looking at how you're going to treat the patient, and a lot of it has to do with the patient's ability to use and wear the contact lenses, and we'll talk a little bit about the difference. Let me go up a little bit because I don't think we need to. Okay, so one of the things that we need to be aware of is what are the risk factors for a child to develop myopia. There was a study called the NICER study that took place in the UK. And what they did is they came out with a really nice set of charts that looked at the primary causes of risk factors for myopia. First one is family history. Having at least 1 myopic parent increases your risk by 6 times. Number 2, early refractive error. That means if you are a +75 or less, meaning more ametropic, at 6 to 7 years, your chances of being myopic by 9 to 10 years is very high. The other thing is axial length. We've only started measuring axial lengths on a regular basis in the last 5 years, but if your axial length at 6 to 7 years is 23.19, you are going to be predictive of having myopia later on. So those are the kinds of things. We also know that the pandemic has changed the prevalence of myopia significantly. Children went from being in a classroom, being outside, being with their friends, to an environment where they were restricted to the home, doing everything that in their life that was important: academic, screen time, socialization. All of those things were taking place on screens. And what we found was the progression of myopia was much faster, but we also saw dry eye disease in this population. And this is just another study that shows the same thing. In Hong Kong, they had 2 cohorts that they were monitoring for refractive error over time. One of them initiated before the pandemic. The second one, the 709 subjects, was the second cohort that started during the pandemic. And they reinforced all the same things. We know that you will see an increase in your work. With the increase in your work time, you'll have an increased screen time and decreased time spent outdoors. Those are the things we know are risk factors for myopic progression. They just reinforce that. The other things we noticed is the fact that we now have to deal with dry eye disease in children. That's something we hadn't even thought about. That was something I used to ask, as I was going through menopause, my friends would be complaining about their eyes. That's when I think about dry eye disease, and not at high school students or elementary school students. That's something that we hadn't even thought about. Now it's a pretty common problem, and we need to address it. We need to teach them how to do a better job. So as we move forward, we need to think about, okay, we know we have problems. We know myopia is increasing. We know we have ways to control myopia progression, but when do we start? Do we start after they become myopic? Well, the problem is there isn't a lot of research out on younger kids. Most of the data is on kids that are 6 to 7 to about 14 or 15. So we don't really know what's going on with them beforehand or after with respect to some of these treatment options. The reality is we've all thought that myopia progression quickly is related more to an Asian background in China or Hong Kong. But this comparison showed that the study that was done in Europe showed exactly the same progression of myopia in individuals that were in the UK, not just the Asian population. So it's universal. This is a pandemic. We need to think about starting myopia control or management as soon as possible. And we need to think about how best to do it for us. I wanted to bring this up because we know vision screenings are really important. The fact is that in England, preschool age kids are really expected to go through a distance visual acuity test requirement. In the UK, there was a steady increase in the rise of kids who failed distance visual acuity starting from 2015 through 2022, but you saw the highest numbers during the pandemic. So clearly, even the 4 and 5-year-olds are starting to show more myopia. I want to just touch on a couple of other things that I think are very significant with respect to practicing with kids. Number one is there is now a gold standard. The International Agency for the Prevention of Blindness has said that a cycloplegic exam is now the gold standard. We know that it doesn't necessarily apply to all parts of the world because they don't have access to medication, but it's based on a study of 10,000 kids in Chicago. We know that kids will show a difference between dry and wet autorefraction if they're less than 10. And we know that if they're hyperopic, it'll be less accurate, a dry refraction. In addition, we now have some data on corneal topography through the Pentacam, which has never been done. We now have a mechanism to start to look at when we can identify a child who might be keratoconic. And then the last thing I wanted to highlight was the fact that amblyopia is no longer just a monocular deficit. It is a deficit of the eye that has a reduced acuity. It is a deficit of the other eye, as well as a binocular neurodevelopmental process that affects fine motor, gross motor, reading, and self-perception and quality of life. And with that, I think I'm going to end by, there are lots of ways to treat amblyopia. I'd like to suggest we keep running through the research to identify what is best for our patients, how can we do it better than ever and have better outcomes and start earlier. And with that, I want to say thank you.
Thank you very much. I know we skimmed through that last bit, so we'll just have to have you back. Wonderful. Thank you very much. So I'm going to open up for Q&A questions from the audience here, and then we'll move. There are currently none online yet, but those who are online, feel free to put those in the chat. So I'll open it up. So let me, I'll bring the mic to you. There.
That was wonderful. What a great presentation. So much appreciated. A quick question regarding myopia. So the increasing incidence, and I know you've commented around China, for example, even the US, is it an issue related to increasing detection? Or is it real, do you think, that there is an increase in the proportion of children that are now myopic? And if yes, it's real, not just detection, is it because of screen time, or what do you think are the underlying etiologic factors that would contribute to the increasing in the prevalence?
Excellent question. So in China, they have taken it on by the government has taken on myopia because they see it is truly increasing in prevalence. No question. It is not just all of a sudden they're coming in. In the United States, sadly enough, our surveillance system is pretty poor. Most of the data on children from 12 or up through the age of 40 is weak or non-existent. It's estimated. So I can't necessarily say, however, I think from speaking to people, the prevalence of myopia in the US is increasing. The things that we look at as etiologies are certainly the genetic piece. So, you know, there's no question that there's a genetic link. That was done in Orinda probably 25, 30 years ago, they identified that. There's also a feeling that, and it used to be that they felt that near demand was really the cause, but I think we're now focusing on the fact that kids are spending less time outside, not in sports per se, but being outside where you're exposed to a certain level of light. And there's a feeling, and there are a couple of scientists that are looking at it, that somewhere along the line, that is more of a risk factor if you don't have some of the other issues. Lifestyle certainly is playing a significant part. We are sitting like this constantly. So I hope that answered your question.
It did. Thank you so much. Yeah, very helpful, very informative. Thanks again
Thank you.
for your time.
Thank you.
Any other questions from the audience here? Yes, I will bring the mic up. It's so much easier. That way I don't misspeak in repeating the questions.
If anyone else has a question, let me know ahead of time so I get the mic to you.
Thank you so much, Dr. Block. You covered so much territory, and I want to go back to something that you spoke about early in your presentation, because I was looking at some press release, some new information that came out very recently that was talking about the increase in autism. And in the state of California, we're looking at numbers of 1 in 22 children on autism spectrum. And you shared the wisdom that children with disabilities have unique visual issues, unique eye concerns. Could you share a little bit with all of our healthcare providers who work with the pediatric population, because they're going to be seeing children on the spectrum, some of your wisdom about the need for eye care with that special group?
It's interesting because I spent a lunch with some of the ladies from first and second year, and that was one of the discussions we had. Children with autism are probably some of the more difficult patients to assess, because oftentimes with autism, sometimes with kids with autism, they avoid your gaze. And what do we do as eye care providers? We expect them to look directly at our target and hold still and do all those things. And what I found is you need to be a really good observer. So when I test kids, and usually it's the kids that are more severe and profound that are the challenge, the reality is autism is a spectrum. You know, you have lots of variability in their ability to respond. We're really only concerned about the ones that are at the more involved level that have poor eye contact. And sometimes what it takes is multiple times of seeing them and watching them. So when I'm working with a child that's more involved, I will actually look to see where they're looking. And you can almost do a full assessment of fixation and follow, EOMs, by just moving things around the room without them actually thinking that you're asking them to do something. The challenge is the refraction. The challenge, and that's always going to be your gold standard, is your retinoscopy. You got to try to get online and get a good image, and you have to be quick. You're not going to use a phoropter. You're never going to put a child who's autistic behind a phoropter. You're always going to do it as free flowing, like you would for a low vision patient. I often will use handheld lenses and not skioscopy bars because I can slip them up and slip them down really fast. But it's a matter of you realizing that you've got to get in there, you got to get in there quick and no dilly-dally. You know, get as much information as you can. And it may take, many kids are in great academic programs where you can get them to practice different skills, and that when they come back, you can get a little more information and a little bit deeper into them. And then I send parents home with pen lights and say, play with the pen light, let them look at the pen light so they know not to be afraid of some of the tools. So a lot of it's not going to be like when you come in for an eye exam, you go in for your full exam, you're done in an hour and a half, and you're on your way. Kids with autism, maybe I might only get 5 minutes with them if I'm lucky, or I might get 15 minutes. And if I can get 15 minutes, I'm going to take what I can get. And then I'm going to move to and say, well, why don't we come back and do it another time? My vision clinic in the school-based program was an old school, and it was a lot more comfortable for kids than in a medical environment. I always take off my clinic coat. I never would wear anything that made me look like a doctor. If you make it so it's more comfortable, and because kids are in school all the time, if they feel like it's a comfortable environment, they will be more responsive. Now, that's not going to give you the answer to everything. It's going to be a process. So hope that helps.
Hello, Dr. Block, and thank you for the lecture. Now, I imagine there's a lot of barriers with increasing standard for eye care in the United States, given just how varied it could be state by state or just county by county, as far as accessibility, healthcare funding, and well, quality of schooling. What would be some methods you can imagine to try to tackle these barriers?
Okay, so, I have so many thoughts and ideas. I don't have the money, but I have the ideas. So community health centers are really a great place that the community goes for healthcare services. A very small number of the FQHCs or community health centers actually have eye care there. There may be some screenings done through, remote diabetic retina screenings, but we need to make sure that community health centers understand the importance of integrating vision into their programs, because it will pick up a significant number. I think now that we know myopia is such a big issue, and there are some other things that we're going to worry about in kids, I think there should be a mandate that a child before they enter school should have a comprehensive eye exam. I think. And then it's the responsibility of the practitioner to say when you think that child should come back. It's not the school's responsibility. It should be our responsibility as a provider to say, your father's myopic, your mother's myopic. You may not be myopic yet, but I want to see you every year because I want to make sure we intervene before it's too late. There is one study that's going on in China with 4 to 9-year-olds comparing a control group to kids being given prophylactically atropine. So to me, I think that one of the goals would be to say, we need to think about where we can best intervene. I would I think we don't talk to the pediatricians sufficiently enough to ensure that they understand the, what are good signs, what are risk factors that that child needs a full eye exam. I would also like to see more school-based vision clinics in lower income programs. Parents don't know what they don't know. It's not that they're doing a bad job. They don't have money. They don't have insurance. They make too much for Medi-Cal, but not enough to be able to go pay for things on their own. They can't take the time off of work because that means maybe they don't have enough money to put food on the table. There's lots of things. School-based vision clinics have worked, and they're in Baltimore, they're in a number of places in Ohio. We had it in Chicago, it's now in Houston. They are a nice catch-all for the kids. I'm not worried about people who have access or knowledge or insurance. I'm worried about the ones that fall in between, the ones that fall through the cracks. So that's just a couple of thoughts.
Thank you.
So Dr. Block, I just wanted to mention about our Western U Health Clinic and having optometry on the first floor. It's been a great partnership with our pediatricians who are doing these screenings, and our patients are familiar with our facilities and coming to get our comprehensive eye exams. I just think it's a great model. You mentioned about surveillance and how little information we have, and absolutely true. We don't even know what the rates of in California, the ones that fail, what percent are actually reaching the doctors. You mentioned earlier that there's a delay, one study about 18 months before they get full eye exam. Do you have some comments about what do we know about the percentage of these children who have been identified to possibly have an eye problem from a screening, who actually make it to an eye doctor for diagnosis and treatment?
So I don't have a good study that would quote the sensitivity and specificity, because that's really what it is. You're looking at how good are our eye care, our screenings. The problem is the screenings vary so greatly, it's hard to come up with a single sensitivity and specificity level for all of the kids that are screened. Yes. So there's always the question, if I make my sensitivity high, I'm going to over-refer kids, and then I'm going to get in trouble from the person who's doing the eye exam to say, why'd you refer this kid? They're totally normal. If you make it too low, then we're going to have the kids that are going to have vision problems, and they won't get to the right resources. So if in my dreams, I would say I'd like to see the National Eye Institute create a nice population-based study that would look at vision screenings, come up with a standardized screening, and that's going to be a very big challenge because it's hard to get two people to agree on that. And it has to be more, because I believe screenings should include near visual acuities, because what do our kids do? They work up close all the time, and we never really screen for near visual acuity. Why is that? So I think we need to come up with a screening protocol that should be standardized, look at the number of kids that are referred, have a full exam for them, because you need to do that as the gold standard, and identify where the weaknesses are in our screening protocols. The reality is I am working with people at the National Center for Children's Vision and Eye Health, and we have 3 papers that we're trying to do for the last 3 years. We're trying to do a birth to 3 recommendation, a 3 to 5-year-old, update the one we have, and try to come up with the school age. The problem is there's no good research out there to tell us what we should do. And I think that's where the gaps are. I think, I want to know the answer to that question. I just don't know it.
Any other questions for Dr. Block? Well, all right. And were there any questions on the chat? I don't want to miss out on our online audience as well. All right. Well, thank you very much, Dr. Block, for your time, your expertise here today. Much appreciated. Thank you. And thank you for you.
Oh, thank you so much. Oh, that's very kind.
All right. Feel free to come up, say hello, and then we will, you all are all excused.
Thank you.